Good morning, and welcome back to day 2 of the meeting. My name is Jill Colglazier. I'm from Mayo in Rochester, and I have my other 2 co-moderators.
I'm Drew Braet, one of the integrated residents from Michigan.
And Matt Blecha from Loyola University Chicago Group.
We hope you all enjoyed the welcome reception last night. I have a few announcements. We want to thank all of our industry partners once again for their support and encourage all of you to speak with as many exhibit reps as possible during our breaks throughout the day. As a reminder to all presenters, please verbally disclose any relationships with industry prior to the start of your presentation. We also want to ask everyone to ensure that their cell phones and pagers are silenced. And I'd also like to remind those who come up to the microphone to ask questions to please introduce yourself. Thank you, and we'll get started. I'll introduce our first speaker today, whose paper is entitled Endoscopic Vein Harvest and Its Effect on Lower Extremity Arterial Bypass Patency by Dr. Justin Robbins from Wright State University and Kettering Medical Center. Thank you.
All right, good morning. I'm Justin Robbins. I'm a Chief General Surgery resident at Wright State University, and today we're going to talk about endoscopic vein harvest and its effect on lower extremity arterial bypass patency. Our authors have no financial disclosures. I am an active duty member of the United States Air Force, and as such, these slides do not represent the U.S. government. The gold standard conduit for low extremity arterial bypass grafting is the greater saphenous vein. Open venous harvesting is often performed for low extremity arterial bypass. However, endovenous harvest was first introduced in 1996 and has become the standard for coronary artery bypass grafting. There have been many studies since endoharvest has been introduced looking at can we use this for lower extremity arterial bypass, and does it affect patency, with mixed results. Some saying it decreases patency, others saying there's no change in patency. In 2021, the Journal of Vascular Surgery, Guo et al., did a meta-analysis of 12 of these studies and found a significant decrease in patency rates with endovenous harvest. Of note, the last study that was conducted was in 2019 by Kronik et al., looking at their institution's experience. And they found no difference in patency rates amongst their 2 groups, and they contributed this significantly to the provider experience with endovein harvest. So our goal was to look at our own institution's experience with endovenous harvest versus open venous harvest and whether or not there was an effect on patency. This is a retrospective study over 10 years. We had 340 patients undergoing infrainguinal bypass using vein, 111 with open venous harvest and 229 with endovenous harvest. 7 years ago, our vascular group hired a PA with 20 years experience in CT surgery with endovenous harvest experience. And since then, we were able to utilize her expertise to perform our bypass. Patients were included if they were greater than 18 and they had a bypass for CLTI. They were excluded if there was no use of vein for the bypass or if there was non-single segment vein. Our outcomes of interest were the primary assisted, secondary patency rates, and we also wanted to look at wound complications. I'm a visual learner, and so I wanted to show kind of the steps of our endovenous harvest to give you an idea. A shows our table setup. We use the Maquette HemoPro 2 harvesting system. We then make an incision medial to the tibial plateau, dissect down to the greater saphenous vein. A blunt tip trocar is then used to dissect proximally and distally along the entirety of the greater saphenous vein. An incision is then made at the medial malleolus, and the greater saphenous vein is identified and a vessel loop is placed. F shows the harvesting system where we identify the branches, and the branches are then cauterized and transected as far away from the greater saphenous vein as possible. Once that's complete circumferentially, proximally and distally, we identify the proximal aspect of the greater saphenous vein, make an incision, and ligate and transect it. The entire vein is then removed in one piece from the incision at the medial malleolus, taken to the back table and prepared in a reverse fashion. When looking at our results, there was no difference in demographics such as age, BMI, sex, race, or comorbidities amongst the 2 groups. We looked at our outflow targets. For both groups combined, it was 25% above knee targets, 74% below knee targets. When looking at open venous harvest versus endovenous harvest, there was an 8% increase in above knee targets with endovenous harvest compared to open venous harvest. 90% of our patients presented for follow-up after surgery. 70% presented for their surveillance imaging. When looking at our outcomes, there was no difference in need for arterial surgery within 1 year or 5 years. There's no difference in need for amputation. However, there was a significant difference in incision breakdown, 12% versus 21%. Surgical site infection, 24% or 25% versus 71%. And procedure duration, it was actually shorter by half an hour at least for the endovenous harvest. There was also noted to be a difference in amputation within 90 days. When looking at our patency rates, there was no difference between open venous harvest and endovenous harvest for primary, primary assisted, or secondary patency. On unadjusted and adjusted odds ratio, with the adjusted odds ratio, there was a lower odd of secondary patency with the endovenous harvest group. So we feel that with experienced providers, endovenous harvest can be a safe option for greater saphenous vein harvest for lower extremity arterial bypass. However, it's unrealistic to believe that every vascular program can hire someone with 20 years endovenous harvest experience. So we think it's important to collaborate with CT surgery groups within your institutions if this is something you want to do, because those providers are going to need the experience with short segment harvest where they can make those errors. And because with some of the previous CT surgery studies, they've shown that less experienced providers more likely injure at the junctions or the ostium when they're doing endovenous harvest. We saw no effect on patency in our group up to 5 years, and there were decreased wound complications. We are limited in the fact that this is a retrospective study, and we did lose 32 patients to follow-up, so we do not know the outcomes of their bypass. We feel that future multi-center prospective studies are going to be needed to better analyze whether or not endovenous harvest plays a role on patency rates, and we feel that our data shows that endovenous harvest is a feasible option for infrequent bypass grafting. These are our citations. Any questions?
Thank you. I'll start off with some questions while we wait for people to come to the microphones. So yesterday we had a paper that contradicts this a little bit from University of Iowa and I believe Henry Ford, where they showed that an open harvest was actually superior in primary and secondary patency, whereas yours showed there's no actual difference. Can you explain why you think there might be a difference in the outcomes of those two papers?
Yeah, in their discussion yesterday I was listening intently, when they discussed when they looked at their patency rates, they also noted that as the years went on, that patency rate difference decreased, and they feel that that likely could have been done. They're not able to know because the BQI doesn't tell you the experience of the harvesters, but they feel that that could be a possible correlation that they were unable to identify with BQI. We use the same provider for all of our endovenous harvest. There's no change. The attendings do not do the endovenous harvest, and if the APP is not available and we need to do a bypass, we will do an open venous harvest in its place.
Okay. We'll open it to the floor.
Hi, Alex Shepard from Henry Ford Hospital in Detroit. It was a nice presentation, and I rise basically to echo the point you just made in terms of our presentation yesterday, and I think your paper is probably a good example of what happens with increased operator experience. However, I personally am still not sold on endovascular harvest. I think it's getting better and better, but my concern is with the marginal vein, the vein that may be 3.5, 4 millimeters in the groin. Then as you get distally, it tends to get smaller and smaller. Below the knee, it's uniformly 2 millimeters. These are people we take to the operating room sometime, cut down, look at the vein, play with it, try to distend it, see if it's something that can be used or whether we need to go with prosthetic or some other conduit. So I guess my question to you is, what was your preoperative protocol for mapping patients? There must have been some patients that you felt were not candidates for vein harvest or for utilization of a vein conduit, and you have lower limits, for instance, where you'll just say this isn't worth it. Again, I still feel that the best technique in terms of not beating up a poor quality vein is open, but endoscopic harvest is clearly making strides, and this, for a good quality vein, it looks like to me it may be the way to go. Thanks very much for your presentation.
Yeah, thank you for your question. So all of our patients preoperatively in PACU will have ultrasound done by the APP and the attending ourselves, and then we will redo it in the OR after they've undergone anesthesia to ensure that it is greater than 2 millimeters. We do not take any veins that are tortuous, dilated, or varicose, or any sclerotic veins. That's when we'll make the decision not to perform intravenous harvests.
Yeah, nicely presented. I just have a comment. Hearing both the presentation from yesterday as well as today, looks like I think this is a skill set that we got to adapt at some point of time. But again, we presented a very similar paper at the Society for Vascular Surgery meeting in June this year. We looked at the 5-year outcomes, basically looking at the endoscopic vein harvesting compared to the open vein harvesting using the VQI Vision database. I think in that data set, we found that the endoscopic vein harvest at higher risk for reinterventions, but in the longer term, there is not much of a difference in the reinterventions or in the amputations concern. But at least in the first year outcome, you will have more interventions for the endoscopic vein harvesting there.
Thank you.
Jonathan, one more question.
All right. John Barth, Mizzou. It's a great presentation, Justin. I have a really incomplete understanding of how this works, but I've been interested in it and watching the past couple of talks. So is there anybody that does an in situ bypass with the endoscopic vein harvest, and then instead of using thermal energy, just clips all the branches after you've run the valvular tone? It seems to me that most of the issues seem to be with thermal injury to the branches and perhaps not being able to visualize the whole thing, but it seems that if you made a small incision, did your endoscopic vein harvest, did the in situ bypass, did the valvular tone, and then clipped all the branches, you'd obviate some of that thermal injury. But I just don't really understand how it works, because, and I'm interested in it. So.
Yeah, so there's not been a described technique yet, and I think one of the issues is that would just require, if that was something of interest, they don't have like clips. It's all electrocautery. So we would have to go to that company as a group and say, we need you to make tiny clips, and we need you to make scissors that can go down there, and then understanding that that's also going to make it longer than if you just have the cautery. Now I have a video, if you want to watch it, a little 3-minute video. It's going to be with my manuscript for JVS, showing our technique.
Right.
Thank you.
Our second paper is titled Midterm Outcomes of Covered and Non-Covered Stents for Femoral Popliteal Atherosclerotic Disease. This is presented by Margaret Kurup and the group at University of Missouri.
I first want to thank the Society for this opportunity to present. My name is Margaret Kurup, and I'm a third-year medical student at the University of Missouri, and today I will be discussing outcomes of covered and non-covered stents for femoral popliteal atherosclerotic disease. These are our disclosures. Femoral popliteal atherosclerotic disease is a condition that has historically been treated with surgical interventions such as femoral popliteal bypass surgery or femoral endarterectomy. However, due to recent surgical advances in the field, endovascular intervention has become first-line treatment for SFA disease for patients who are poor surgical candidates or require a less invasive alternative. Endovascular intervention for SFA disease usually utilizes one of two major types of stents, the covered or non-covered stent. And while many studies have looked at the long-term outcomes and patencies of each of these stents individually, there are very few studies that have directly compared the outcomes and long-term patencies of these stents to each other. Therefore, the objective of our study was to retrospectively analyze patients that underwent endovascular intervention for SFA disease and either received a covered or non-covered stents, and we analyzed long-term patency and outcomes. In total, we had 119 patients with complete data, 50% receiving covered stents and 50% receiving non-covered stents. Claudication was our main indication for treatment. However, of note, less than 50% of the patients presented with claudication as their main indication for treatment, suggesting that many patients may have presented later in their disease course with more severe symptoms. The non-covered stent cohort had a greater mean age, while the covered stent cohort had a greater significant proportion of comorbidities and a significant history of prior SFA intervention. While I appreciate that this slide is very busy, the main takeaways are that the covered stent cohort presented with a greater proportion of task C and D lesion classifications, a greater mean popliteal runoff score, and a greater mean length of the SFA lesion being stented when compared to the non-covered stent cohort. In our univariate outcomes, we saw that at midterm follow-up, the covered stent cohort presented with lower mortality, lower rates of leg ischemia, and fewer reinterventions than the non-covered stent cohort, with the non-covered stent cohort undergoing more endovascular and open reinterventions. As well, there was a greater proportion of endovascular and open reinterventions than hybrid reinterventions. And we then took out of our total cohort the cohort of patients that underwent reintervention to analyze for significant differences. The only significant difference we saw was that the covered stent cohort underwent fewer reinterventions than the non-covered stent cohort. We did not see any differences in perioperative variables within this cohort. In our gender subgroup, we saw that females presented with more acute limb ischemia and less critical limb-threatening ischemia than males. We also saw significant differences between the size of the CFA and the size of SFA stent used. We did not see any differences in perioperative variables, such as pre-op or post-op ABI, task classification, or SFA size. We then ran logistic regression models on mortality, leg ischemia, and reintervention. Reintervention was our only model that presented with a significant risk factor of diabetes. Of note, in our multivariable analysis, covered stents did not persist as an independent risk factor for reintervention. We then examined patencies at a mean follow-up of 30 months. We did not see a significant difference in primary patency between the stent cohorts. We did see a significant difference in primary assisted patency between the stent cohorts with a p-value of 0.04. At 30 months, we did not see a significant difference in secondary patency between the stent cohorts. We analyzed survival outcomes at a mean follow-up time of 36 months and did not see a significant difference between the stent cohorts at this time. From this study, we now understand that covered stents were utilized in patients with a prior history of SFA intervention, a longer SFA lesion length that was stented, a greater proportion of task C and D classifications, and a greater mean popliteal runoff score, while the covered stent cohort was also associated with a lower reintervention rate, a lower leg ischemia rate, and similar patency rates to those of the non-covered stent cohort. Our conclusions include that gender differences do exist. We saw a higher rate of acute limb ischemia in women. Whether this could be hypothesized to be due to physiologic differences, anatomic differences, or a combination of both remains unclear and something to be further researched. We also saw that despite more complex lesions and a previous history of SFA procedures, the covered stent cohort was able to maintain similar patency rates and fewer reinterventions than the non-covered stent cohorts. Therefore, covered stents may be a preferred treatment in patients that present with a more complex past medical history, including a more significant proportion of comorbidities or a previous history of SFA intervention. As well, it may be a preferred treatment for patients who present with a more severe symptom profile, including those that present with acute limb ischemia. I'd like to thank you all for listening and for the Society and Dr. Bath for this opportunity to present. Thank you.
This paper is open for discussion.
Ross Miller, Chicago. I just want to make a quick comment. Amazingly good job for a third-year medical student. We've had other students present over the years and at this conference, but always super impressed with medical students who get up in front of an audience like this and present with that much poise. You should be congratulated. Nice job.
Thank you.
Frank Davis, University of Michigan. I agree. I echo those comments. Great job. My question, kind of a follow-up question to your data set that you presented today. Did you at all look at adjunctive procedures that were done at the time of potential stenting, such as drug-coated ballooning, atherectomy, or shockwave? I know that might be a complex question for you, and I do apologize. I'm just curious.
I'll defer to Dr. Bath.
John Bath-Mizzou. So we do have the data. There were a lot of adjunctive procedures performed, femoral endarterectomies, some in the setting of bypasses, and all the other modalities. It's probably something that I'll put in the supplemental table. I mean, it's just a mismatch, as you can imagine, of things, and we looked at it to see if there were any themes. Clearly, this, just as a comment, clearly these data are not surprising to anybody who's followed covered stents, but I mean, you know, what's surprising to me is that you can take a patient with a worse popliteal runoff score with an SFA lesion that's, you know, a full metal jacket in a patient who's got thrombus and needed thrombolysis and obtain similar outcomes, you know, at 2.5 years, 50% patency to those who are essentially naive to stenting, which for me really speaks to, you know, selective use in really bad patients for covered stent.
I'll echo again, very good job. My question, maybe for you, maybe for Dr. Bath, the question gets to like how, what I noticed about your curves were the secondary, or the primary assisted patency was different, secondary patency was similar. Primary patency looked different, maybe just didn't have power to see that difference. And do you follow the patients differently in a covered stent versus an uncovered stent? Because edge stenosis, usually it's fine, thrombosed. Whereas uncovered stents, I usually see them come back with claudication or some sort of mild symptoms before. And so do you change your follow-up algorithm for people based on the type of stent they get, because you don't always get great signals before a covered stent goes down? Thank you.
Sorry, it's a great question, Randy. I'd like to say I did something different with them, but we really don't. And, you know, I see these patients for life or until they die, or I move somewhere else for every 6 months. But you know, folks, I think, have seen these patients routinely, and I don't know what to do with this. I get an ultrasound every time. I get an ABI, and you're right. Between, you know, they look fine, and the next week they occlude. I also keep them on dual antiplatelet agents for life, and I've even been aggressive in some young patients and done PADs, so Xarelto, aspirin, and Pavix. And people always call me, why are you keeping them on such an aggressive regimen? But I have nothing, no other data to support it. I will say a couple of anecdotal things. We've used them sometimes in trauma situations, certainly in old people with popliteal injuries. And we have ones that are going on 5 or 6 years that every now and again we might refresh. But I mean, it's amazing how durable they can be in patients that are relatively normal. So.
John, I was going to ask you a follow-up question to that, because my question was, what is your difference in regimen of antiplatelet or anticoagulation therapy in covered versus uncovered? Do you think that has any additive benefit or difference between the two groups?
Yeah. I don't do anything differently. As I said, I've become even more aggressive. People thought it was aggressive before, but I've become even more aggressive now with sort of triple therapy with very little data to support it. But I do that routinely for any stents, actually, so I'm sort of biased in that respect.
So no difference between covered versus uncovered?
No, not really.
Okay, thank you. Yeah.
Very nicely done. I had a couple questions. So first of all, in today's world of cost containment, do you have any cost differences for the covered stent? Because it's 3 times higher than a bare metal stent, and your 3-year patency was no difference. And I do think in today's world, in 2024, as opposed to 30 years ago, you can't just describe patency without clinical outcome. Patency is irrelevant if you don't have an improvement in your claudication, if you don't have limb salvage. I think survival is not a good surrogate endpoint for people with claudication, only for critical limb ischemia. But I think you have to add that to make the paper more robust. But very nicely, John, and just answer the questions. Thank you. You, not Jonathan.
Just to answer that briefly. So, Mark, I think patient-reported outcomes are extremely important. Obviously, in a retrospective study, I'd have to think going forward, find the patients and ask them these questions. We don't routinely ask them, probably an SF36 or something like that during clinic. But I think that, yes, going forward, it's really important to survey. Obviously, we could look back at the clinic notes, and usually most of them don't report claudication, or they do. Secondarily, gosh, I forget if there's a second portion of that. Because, Vyvanse stents are expensive, clearly. You mentioned that the patency is similar at 2.5 years, 50%. However, I would argue that the cohort that we place them in is much biased. I mean, higher popliteal runoff scores, higher amount of S failure intervention. So this is a worst population that we're obtaining similar results to bare metal stents. So that, for me, argues for using it selectively in really complex lesions.
All right, thank you.
Okay, next we'd like to welcome Jacob Shapiro to present initial experiences with the treatment of thoracoabdominal and pararenal aortic aneurysms with visceral artery in situ fenestration using radiofrequency and biplane angiography.
Good morning. Thank you to the Society for the opportunity to present today. I don't have any relevant financial disclosures. So endovascular treatment of thoracoabdominal aortic aneurysms and pararenal aneurysms is a complex problem for vascular surgeons. PMEGs, or physician-modified endografts, have been described in the literature and also utilized at our institution to treat this problem. Various methods for PMEGs exist, including back table fenestration with reconstraining of the graft and in situ laser catheter fenestration. But starting in October of 2022, our group began utilizing in situ fenestration with the radiofrequency ablation wire, which has been FDA approved in the venous space, and we've published on that in the past, and the biplane angiography C-arms to improve operative efficiency and patient outcomes. So our study was a retrospective review of patients with thoracoabdominal and pararenal aortic aneurysms treated with in situ radiofrequency fenestration and biplane angiography from October 2022 to February of this year. And patient and case characteristics and outcomes are on the following slides. So as you can see there, our mean patient was just over 73 years old. The vast majority were male patients. The average length of stay was about 9 days, and 3 out of 15 patients had a prior EVAR. They had the normal distribution of medical comorbidities, and most patients were smokers. Luckily, few patients were obese, and few were on therapeutic anticoagulation preoperatively. So here are some outcomes from our cases. So pre-stenting in that first row there, is referring to pre-EVAR intervention, where we would put stents in the visceral vessels in order to help ease the cannulation and identifying the visceral vessels during the actual repair of the aneurysm at a later date. And we adopted that pretty early on in our cohort here. And then for biplane angiography usage, we also did not adapt that initially, but then we adapted it relatively quickly, and it was used in 11 out of 15 patients. Our elapsed surgical time was roughly just over 3 hours, with just over 1 hour of fluoroscopy time and just over 200 milliliters of contrast used on average. The median number of visceral vessels cannulated was 3, and as you can see there, we had 0 vessel perforations in this group. And then for renal stents, all 14 patients that received renal stents had stent patency with 30-day follow-up. We did have one SMA stent that went down within 30 days of the procedure. It was 4 weeks after the surgery itself, and I believe it was due to a highly diseased vessel with poor outflow. In that patient, the celiac artery was occluded at the outset of the procedure already. We did have some endo leaks during the procedure, 6 total endo leaks in 4 patients. Most of them were type 2s, and then there were 2 type 3s. One was a 3A, and one was an iatrogenic 3B. Which led to the secondary interventions you see there. Luckily, our postoperative complications were relatively low to none. One patient did develop an acute kidney injury. And then lastly, 3 of our 15 patients passed away, 2 of them to unrelated reasons, and then one of them, the patient whose SMA stent went down, as I mentioned, ended up passing away from that. So a little bit of discussion about things that we've learned from this technique. So pre-stenting the viscerals has helped immensely in decreasing operative time and fluoroscopy time and contrast uses as well. And the biplane angiography has also been pretty crucial in orthogonal viewing of the visceral stents and being able to aim our directable guide sheath in 2 different planes to line up for the fenestration. We routinely utilize the 16 French Aptus guide sheath that is typically intended for Medtronic endo anchors when we attempt to fenestrate, and that really helps with support. The Navicross catheter, once the fenestration is created, has been much more successful than the CXI catheter. when crossing the fenestration after the wire goes through. Typically after that, we utilize a 4 or 5 millimeter by 40 millimeter PTA catheter to pre-dilate the fenestration and then subsequently place our covered stent. And in cases where we have been unable to track an 035 system, we've had some success with 014 coronary balloons, and that's gotten us out of a few binds. And then lastly, a stiff buddy wire or sheath is sometimes left in a tortuous visceral vessel outside of our main body endograft in order to straighten out that vessel and ease cannulation as well. So in conclusion, in situ radiofrequency fenestration and biplane angiography used in conjunction has helped decrease morbidity and mortality during repair of these complex aneurysms. And this technique is worthwhile to add to your armamentarium if you have the equipment to do so. With further experience, we do anticipate that we'll have lower surgical times, lower fluoroscopy usage, and hopefully more improved outcomes. And our thought is that this spares complicated patient population from a maximally invasive open operation.
Great, thanks.
Oh, sorry, I had a couple more slides if that's... So with respect to existing data on in situ fenestration, a group out of France did perform 108 visceral vessel laser fenestrations for various reasons, including thoracos and pararenals. And I did have my presenter notes up here, and I had some information about they had some pretty good outcomes as the bottom line, and they showed that this is a feasible technique, while Dr. Panaton did recently talk about his use of the laser catheter in the subclavian space at a conference earlier this year, and showed that they have some long-term good patency data and outcomes as well. And I believe there's some further data to be coming out about that later this year. And then lastly, a little bit of information about the celiac axis. So most of our patients in this cohort, we've covered the celiac axis for multiple reasons. Some being it's already occluded or highly stenotic, or we've proven on preoperative angiography or CTA that there are patent collaterals. And there's some mixed data out there about the outcomes of this. Some recent data showed that there's worsening outcomes if the patient has celiac coverage in terms of mortality and intestinal ischemia requiring intervention. But then two other groups there, as you can see, have shown that in the selective patient population, this is actually a safe and feasible technique. And that's all I got. Thank you.
Okay. One quick technical question maybe for Dr. Muck. So the two cases where you did not pre-stent, are you just using the angio and road mapping to determine where to fenestrate?
Yes, that's what we did.
Okay.
Me first?
Yep, go ahead, Ross.
Hey, Jake, very nicely presented, and it's hard patients, I know. Now with the FDA approval of TAMBI and the availability of TAMBI, how many of these patients would have an on-label sort of approach with TAMBI? It's good to have this technique because not everybody is a candidate, I realize, but it's also probably better just for overall medical legal reasons to be able to use an on-label approved device than this approach.
That is definitely something we've talked about amongst our group, and one of our staff recently went and underwent training for TAMBI, so we're hoping
Hopefully
to...
not Pat.
It wasn't him. But we are hoping to get some TAMBI cases soon, but we just, in the interim, this has been a useful technique.
Yeah, one of the hard parts at the beginning is you have to be strictly on label for TAMBI, which probably, if I would have to guess, all 15 of your patients wouldn't be on
Probably
label.
not. Thank you.
Jonathan.
John Barth, Mizzou. Pat, I'm really glad that you guys presented this because I've been worried to present our series. We have about 40, because of some of those implications. And I actually went to the trouble of pursuing an IDE, and the FDA were very, very reticent that we have an IDE for just emergency cases only right now. But just a couple of technical things that might be more relevant for Pat. So you guys don't, even if you pre-stent or do not, what's your bailout if you can't do this? I noted in the abstract there are a couple of parallel stents. Do you leave sheaths in from above? I'm always surprised that folks pre-stent, go for it, and then don't have any sort of backup. And I've always left sheaths in from above to bail out with a chimney if absolutely need be. So that's sort of first question.
Yeah, great question. I mean, for us, if it's downgoing, if it's tortuous, And I think Jake alluded to it. We'll leave a 6 French from the contralateral femoral and leave a stiff wire in to kind of straighten it out as a bailout. If it's straight, if it's not early branching, certainly if it's upgoing, then we don't leave a bailout. Now maybe that's irresponsible. We're still trying to learn it, but typically when you pre-stent it, and until you do it in a biplane room, you don't really appreciate the value of being able to see the lateral. So far we haven't had that issue, but we worry about bailouts on early branching, certainly downgoing renal.
Gotcha, yeah. And I think that's one thing that we didn't do early in our experience that we do now routinely is instead of using biplane, we do a 2-view. And certainly, you need to see that down the barrel view and then this side, because on some of the post-op CTs, you can see the fenestration kind of migrating like this, which is probably why one of those stents, the SMA and the renal stents go down, because they're not, they're very tortuous into that vessel. But cool, thank you.
Thank you.
We'll have time for one more question. For those who have questions during the coffee break, please find the authors. Go ahead, Frank.
Hi, Frank Caputo, Cleveland Clinic. 2 things I was just wondering, what is durability with this, right? So that's number 1. Number 2 is, what's your platform? Are you using it across all aortic platforms? Are you using Gore, Terumo, whatever, Cook, whatever those are?
Sure.
But what's your main platform, and what about durability?
So to speak to durability, we have from 2022 to now, and our outcomes have been as I presented. So far, so good. We've had a few endo leaks and had to do a few secondary interventions, but for the most part, there's been type 2 or iatrogenic type 3 endo leaks that we've just recovered. Or one patient, we actually put a VBX through an old fenestration and then coiled the VBX to occlude it, and it worked pretty well. So durability, so far so good, but time will tell. And then with respect to your second question about platforms, we've used Terumo, we've used Cook, and primarily we use Medtronic, and for the last 10 or 15 or 20 of them, we've used the Medtronic Valiant platform, but we did have some experience with the Terumo and the Cook platforms, but we've since moved along from those. Thank you.
Okay. Next is the paper, TVAR in Connective Tissue Disease Patients is Not a Definitive Option, presented by Dr. Brian Cass from Cleveland Clinic.
Thank you for the opportunity to present our work to the society. Thank you. And it's an honor and privilege to be here. So I have no disclosures. So as we know, patients with connective tissue disease are at higher greater risk for aneurysm formation and dissection, especially within the thoracic aorta. And the gold standard for repair in this population has been open surgery. However, other than some dated and small single-center studies, little is known on the efficacy and durability of TVAR in this population. So our aim was to perform a large contemporary single-center study to analyze short and midterm outcomes of these individuals with connective tissue disease who underwent TVAR as a primary index operation for thoracic aneurysm or dissection. It's not green? Yeah, green. There we go. All right. So we looked at patients between 2014 and 2021, included patients over the age of 18 years old who had documented connective tissue disease and underwent TVAR for aneurysm or dissection. We excluded patients who underwent TVAR as a planned bridge for open or hybrid repair. And in total, we had 40 patients with a mean age of 53 years, a slight majority of female. Majority of these patients had Marfan's. One patient had Loeys-Dietz. The rest of the patients had non-specific connective tissue disease that was related to genetic mutations, age, and other clinical findings. 80% of these patients had a prior history of aortic surgery, and in total, majority of patients had aneurysm, and 82.5% had dissection. A total of 35% of patients had both aneurysm and dissection. So if you look at our 30-day outcomes, they're relatively good outside of 2 deaths. One was a patient who presented with a rupture and family decided to withdraw care early post-operatively. And another patient was a patient who represented after discharge with chest pain, found to have rapid aneurysmal degeneration, was planning to undergo a open repair and suffered cardiac arrest after SA drain placement. But otherwise, our outcomes were good with relatively short hospital stays and few returns to the OR. However, beyond this 30-day outcomes, we found that a majority of patients, 22 of the remaining 38 patients, had aneurysmal degeneration. And if you look at our conversion to open repair, we had 15 patients who underwent a conversion to open repair. When we look at the re-interventions, a majority of patients underwent a re-intervention, 25 of the 40 patients in total. And the median time to re-intervention was 9.1 months. 18 had one re-intervention, 7 patients had 2 or more re-interventions. Those re-interventions were for a multitude of indications, but most notably it was aneurysmal degeneration. The types of re-interventions included open repair, TVAR extension, just to name a couple. And then here are Kaplan-Meier estimates. As we found, the majority of these patients who underwent open conversion or re-intervention, these occurred within the first year post-operatively. So in conclusion, TVAR for connective tissue disease patients can be performed safely with a low incidence of 30-day outcomes. However, aortic morbidities, most notably aneurysmal degeneration, is common and should be expected. These are patients who are likely to need to undergo additional re-interventions in the majority of these patients and should be followed closely. Re-intervention in conversion to open repair is more likely to occur within the first year post-operatively, and therefore we believe that TVAR connective tissue disease patients should not be considered as a destination option. Some limitations are that this is a single center study, that we had a lack of direct comparison to an open repair group, and lack of significant outcomes beyond 3 years. Thank you.
Thank you.
We'll open the floor up.
John Matsumura from Colorado. This is a great paper. I'm really glad you put this together and hope you get it published. As you know, none of the trials included these connective tissue disease patients when it was known. And yet, with TVAR, we're using this. I think everybody is using it at least once or twice for those desperate patients, right? And you've got 40. My question is, really 2 questions. When you say it was the primary therapy and you were not expecting to stage it, what were the landing zones? Does this include those patients who have a proximal graft, a distal graft, and you're just doing the bridge? Because I think maybe that's an isolated subset that might have durability. My second question is, it looks like at 2 years it flattens out, and you're not re-intervening on these, and it's a 10-year study. So the patients that it is durable on, are those the unknown connective tissue disease, or does that include the known Marfan's, known Loeys Dietz? Thank you again.
Yeah, thanks for the question. So a majority of the patients, we performed this between 2019 and 2021. There was a handful that kind of went back to 2014, and so that may be a little confounding there. As far as the landing zone question goes, some of them were landed in proximal grafts. Very few, I don't think actually any were landed within grafts distally. And so there was some were landed in the grafts proximally. As far as there was no significant difference in these non-specific versus Marfan, so we didn't find any favorability for patients with kind of that fell in that non-specific group.
Louis Cabani from Detroit. Very nice study, and again, to echo Dr. Matsumura's comments. I'm really interested in the people who worked and people who did not work. Did you subcategorize them and say, the people who didn't work, we landed in mid-thoracic, or like Dr. Matsumura, they had Loeys Dietz or something else, or did you not go that deep into the data?
Yeah, so I looked at where they degenerated at. Was it proximal to the graft, within the graft itself, or distal to the graft? We found that it was pretty split throughout. There was no pattern, or trend with that. And like I said, there was no favorability between the subgroups that were significant.
And there are patients that did well with the TVAR, and so far they're doing very well, and you're following them up, correct?
Some of them. It's a challenge. Our facility, we get a lot of outside referrals, and a lot of these people go home and sometimes don't follow up. So there is a lack of the records. If they did not come back. We were able to get some of these records if they choose to send. We did have some patients who had an open conversion done at an outside facility, and I was able to obtain those records, but that was a challenge.
Good study. Thank you.
Thanks.
So Alameda Alabi from Atlanta. I am at a center where we take care of a lot of these patients. And I think for people who take care of a lot of these patients, we know, genetic aortopathies are a bit of a mixed bag. I know that my friend Shireen Shalhoub will probably say a lot about this tomorrow in her invited talk, but there are some genetic types that may be more amenable to thoracic endografting as opposed to others who would not. So I would caution the authors just about the kind of all or none, everyone in this bag perhaps should not have destination therapy with TVAR, because perhaps there may be phenotypes who would benefit from that.
Yeah, that's absolutely fair. Thank you.
And then in terms of location of failure, are you seeing it directly at the proximal distal fixation points of the stent or at a higher rate, say, than in other areas of the aorta, or is it?
It was kind of mixed all over. There was no, patients, it wasn't like, we saw a majority of patients degenerate proximally distally within the graft. It was pretty spread evenly, and so did not think that was necessary to
like the trauma of the stent itself wasn't causing focal.
Yeah, and that's why I looked into it. I thought that we would find a trend, and we just didn't.
All right. We'll move on to the next paper.
Our next paper is titled Socioeconomic Disadvantage is a Leading Risk Factor for Major Amputation Following Emergent Infrainguinal Arterial Bypass Surgery. This is presented by Megan Chicochi, and this is from the Loyola Group.
Thank you. Here are my financial disclosures. So clinical guidelines dictate that surgical bypass should be used for long segment arterial occlusive disease in conjunction with advanced limb ischemia. Emergent revascularization should occur within hours to prevent nerve damage and necrosis. Significant morbidity, mortality, and risk of amputation are associated with infrainguinal bypass surgery. Although racial and ethnic disparities have been widely studied in the medical literature, they continue to persist. Likewise, geographic variables such as residence in a disadvantaged community have been found to have additive impacts to health outcomes. However, there exists a gap in knowledge understanding the interplay between these variables. The purpose of this study was to use the Area Deprivation Index to establish the relationship between geospatial risk factors and the risk for major amputation above the ankle, both during index hospitalization and at any time following an emergent infrainguinal bypass surgery. The Area Deprivation Index, or ADI, was established by the University of Wisconsin School of Medicine and Public Health and is a validated composite score consisting of both social determinants of health, such as, but not exclusive to, housing situation, income, education level, occupation, and access to transportation, and may be linked to a patient's zip code. It ranges from 0 to 100, with higher numbers indicating more disadvantage. We hypothesize that the ADI may be associated with emergent lower extremity revascularization outcomes independently of traditional demographic factors. We queried the Vascular Quality Initiative from 2003 to 2022 and found approximately 75,000 infrainguinal bypass surgeries. After applying our inclusion and exclusion criteria, we included 2,126 emergent infrainguinal bypasses. We then conducted a univariable and multivariable analysis to understand how social or demographic factors, comorbidities, and surgery-related factors are associated with the risk of amputation. We performed two subgroup analyses, risk of amputation at index hospitalization and the risk of amputation at any point during the follow-up period. We then used these to create a risk score. During the index hospitalization, we found that the top 10% of the ADI, that is the most disadvantaged patients, were significantly associated with the risk of amputation during the index admission. Conversely, we found that traditional demographic factors such as race or gender alone were not significantly associated with risk of amputation. In terms of comorbidities, with the exception of the lack of statin use preoperatively, no comorbidities present on arrival were significantly associated with the risk of amputation during the index hospitalization. In terms of surgical variables, a tibial and pedal target as well as the prosthetic conduit were found to be significantly associated with amputation in the multivariable regression during the index hospitalization. During the follow-up period, there existed a trend such that patients with greater disadvantage experience higher rates of amputation. Likewise, in the multivariable regression for amputation at any point during the follow-up period, we found that the top 10% of the ADI, that is the most disadvantaged patients, were significantly associated with amputations. Tibial and pedal targets, as well as prosthetic conduit, continued to be significant during the follow-up period. Additionally, postoperative wound infection and postoperative bypass revision or thrombectomy were significantly associated with amputation risk at any point during the follow-up. Post-op bypass revision was the most impactful factor. Using these variables, we created a risk score with quality accuracy that incorporated both the social determinants of health as well as medical factors. We included all variables that were significant in the multivariable analysis and weighted them based on their respective beta coefficients in a point-based scale. 1 point was awarded to patients with prior infrainguinal bypass surgery and those who underwent endovascular intervention. 2 points was awarded to those with prosthetic conduit and post-op wound infection. 3 points was given to patients with the highest 10% of the ADI, that is the most disadvantaged patients, and those having a tibial target. Finally, 5 points was given to those who underwent a post-op bypass revision or thrombectomy. A total score was calculated for each patient, and the percent amputation for each score was calculated and presented here. This study is not without its limitations. Being a large data set, it may lack clinical complexity and patient history. Further, the classification of emergent is surgeon and institution dependent. However, the Vascular Quality Initiative does define emergent as happening within 12 hours of arrival. Further, the long-term amputation rates may be underestimated as the amputation variable was not available in the past 90 days for approximately 1/3 of patients. In conclusion, the neighborhood disadvantage is a leading risk factor for amputation after emergent infrainguinal bypass surgery, both during the index and follow-up periods. Comorbidities present on admission were not significantly associated with amputation after an emergent infrainguinal bypass. In terms of surgery-related variables, significant amputation risk factors included prosthetic conduit, tibial and pedal targets, and thrombectomy or bypass revision. We have developed a risk score that incorporates the significance of the ADI with medical variables to help better predict those at risk of amputation. Thank you.
Really nice talk. I'll kick us off with a question while we wait for people to come up. So I understand you addressed this partially in the limitations, but the emergent kind of indication, are you able to tease out in the VQI in your data set whether that's for acute limb ischemia or a patient with CLTI and an advanced wound that you're just not going to sit on overnight, and whether that affects your outcomes?
Yeah, we did include acute indications for emergent infrainguinal bypass surgeries. However, there does a limitation of the study is that we don't have pre-op data, so we don't, entirely know what the baseline of the patients were.
Yeah, just follow up on that. So the inclusion was you had to be designated as an emergent operation, which means that the surgeon dictates it has to be done within 12 hours. That's the VQI definition of, quote, emergent. And then we excluded trauma, tumors, and aneurysms. So everyone had to also, in addition to being labeled emergent, have a diagnosis of either acute limb ischemia, rest pain, or ulceration. So there are like 6 indications in the VQI for bypass, and then there's an emergent, urgent, and elective designation.
Dr. DiMartino.
Hi, thank you very much for the presentation. For emergent cases, it's always you're sort of given what you're given when they show up, and so the deprivation index sort of may not play into how they come to you. But how do you propose we sort of use this? So in terms of intraoperative decision making, which might impact your immediate outcomes or your post-discharge outcomes, do you guys sort of look at this and say, there might be a bundle that we would advocate, use saphenous vein whenever possible, even if it's going to take you longer, or those sort of things, and how would you recommend we sort of implement this? Thank you very much.
Sure. On the doctor-patient scale, I would say, the study can be used to heighten vigilance around patients at risk for an amputation risk. On a more of an institution-level scale, there is precedent in which the ADI may be incorporated into electronic medical records and may be used to indicate patients at higher risk. So that could be done as well.
Yeah, and I think The extra effort for vein is often worth it. We see in this study, as well as studies looking at elective bypass in VQI we did last year, that's one benefit of the VQI is you get really robust numbers, and it just holds up really well. The vein is worth it if at all feasible. And then, obviously heightened vigilance postoperatively. Identify patients who may not have access to medications, surveillance, and it's really worthwhile to get folks on the right meds and surveilled.
Dr. Mattis.
Hi, very nice talk. So my question goes a little bit more to the extreme. Would you recommend to all of us to using the ADI to make the decision before you go to the OR and say, sir, sorry, your index is way too high. You will get an amputation later. We might as well do the amputation now to prevent deconditioning later on and give you the best chance to walk with a prosthesis. Because what we found is that whenever we try and save legs that are at a high risk, a year later we're doing the same thing we would have decided at day one, and there are 12 months of deconditioning. Just like to get your thoughts on that. Very nice paper.
Thank you. I don't know that I have the clinical decision-making skills as an M2 student to make that call, but perhaps Dr. Blecha can comment on that.
It's obviously a case-by-case basis. And when someone presents to you, you have no idea what their ADI is. You're looking at an acutely ischemic limb that needs to be urgently operated on. So I think that's more of a question for the extent of tissue loss, perhaps, or the extent of neurological deficit that's present. And when you have profound tissue loss or profound neurologic deficit where you don't think there's meaningful chance for salvage, then moving to amputation more rapidly makes sense. I think it's more the benefit of the ADI and just looking at patient factors like are they uninsured, their education level is really, getting them, getting a heightened vigilance to make sure these folks are followed up and that they're on the right medications postoperatively in terms of what you're going to do as a physician with this data.
We got time for one more.
Very nice paper. I always worry about transfer time. When I see emergency surgeries happening, are patients getting transferred in? We know some pathologies transfer time is good, right? Because it helps your survival, ruptures. It takes a long time to come in. That patient kind of self-selects out. Acute limb ischemia or critical limb ischemia is not that, right? We know that time is bad. So how many of these patients, I don't know if you can figure that with you, but were transferred in after being at another hospital? Were they coming from a doctor desert where there was no vascular surgeon and they're coming to see, and then eventually they're coming in? How many with them at the point of no return? So
we didn't look at that in this study. However, the ADI does take into account access to transportation, and so that would be something patients in a higher ADI may have less access to transportation, and therefore that could be a potential reason as to why they have a greater risk for amputation.
Yeah. And that actually is a great suggestion because the VQI does have if a patient was transferred, and that's something we could look at retrospectively to see. And that obviously would be a more prolonged ischemia on average. And then also folks are presenting likely with more advanced, like we have those three indications in this study where they had to be designated as acute limb ischemia, have rest pain, or tissue loss in combination with being emergent, but we didn't look into ADI versus those indications per se. So, it's a pretty good guess that folks are having a longer delay to presentation and having more advanced limb ischemia with respect to the extent of tissue loss, et cetera, from areas with less access to healthcare baseline, less healthcare literacy.
Great talk.
Thank you.
Okay, next we are going to welcome up the group from Bay City for incidence and risk factors associated with postoperative index leg ischemia following endovascular abdominal aortic aneurysm repair.
Okay, good morning. My name is Matt Leverich, and I am a JD MD student at the University of Toledo, aspiring to be a vascular surgeon. I would like to thank the program committee for the privilege and the pleasure of the podium. So the authors have no disclosures or conflicts of interest. So institutional retrospective cohort studies with relatively few patients have suggested that leg ischemia following any type of abdominal aortic aneurysm repair is low, approximately between 2 to 3%. In these limited studies, leg ischemia is often devastating. leading to overall increased morbidity and mortality. Risk factors and other postoperative complications associated with it are understudied. Okay. In the present study, our aim is to focus exclusively on the immediate postoperative period to characterize any risk factors and other postoperative complications that may be associated with leg ischemia following endovascular aortic aneurysm repair, commonly known as EVAR. Okay, so I think we got to go back one. There we go. To construct the current study, we queried the Society for Vascular Surgery's Vascular Qualitative Initiatives EVAR module from 2003 to 2022. We identified 57,117 patients with a potential for follow-up analysis. 487 patients were identified with leg ischemia in the index hospitalization period. Factors were compared utilizing a multivariate model to predict leg ischemia during this time period. Okay. While the VQI offers a plethora of variables that can be studied, we opted to study these factors specifically in a multivariate model after they were found to be associated significantly with leg ischemia in a univariate model. They include body mass index, tobacco smoking, abdominal aortic aneurysm rupture, operation time, access site complications, including hematoma or occlusion, intraoperative blood loss, iliac artery adjuncts, postoperative myocardial infarction, intensive care unit stay, and postoperative intravenous blood pressure support. So first we offer some general results. As we mentioned, our cohort consisted of 487 patients. The age group that contained the highest number of patients with leg ischemia was the 65 to 74-year-old age group. 63.4% of patients were assigned male sex at birth. 86.7% of EVARs were performed on an elective basis. And approximately 40% of patients had index hospitalizations of 8 days or longer. So now moving on to our multivariate model. All factors in this model were predictive of leg ischemia. However, the factor most predictive is an access site complication in the femoral artery, namely a hematoma or an occlusion, with an odds ratio of 20.2. Other factors predictive of leg ischemia in order of most to least predictive are as follows. Postoperative IB blood pressure support with an odds ratio of 2.85, a procedure time greater than 2 hours with odds ratio of 2.30, current smoking status with an odds ratio of 2.30 as well, body mass index over 25 with an odds ratio of 2.17, postoperative myocardial infarction with an odds ratio of 2.10, an intensive care unit stay of any length with odds ratio of 2.07, an iliac artery adjunct with an odds ratio of 1.76, an estimated intraoperative blood loss of 300 milliliters with an odds ratio of 1.59, and lastly, a ruptured abdominal aortic aneurysm with an odds ratio of 1.56. Okay. Our study has some notable strengths. Number one, it utilizes the most granular large registry data set, the VQI, for vascular procedures in the United States. Number two, using this data set gives way to a study that has a large amount of power. And number three, multivariate models are more likely to predict complications when we think of human beings as the sum of all their parts and the accumulation of all the physical events that happen to them over their lifetimes, as opposed to each insult separated in time and space in the manner that univariate analyses examine these factors. Okay, our study does have some limitations. Number one, it is retrospective in nature. Number two, given the sheer number of variables the VQI seeks to collect information on, some variables are not well reported. Hence, some of the variables we wanted to study simply could not be studied. The data reporting is highly subject to the site-specific reporters, and it is not independently audited. Number three, we also could not study the specific EVAR devices that were utilized in the patients with leg ischemia due to data restrictions imposed by the VQI. So overall, the major takeaway from our study is that if you have a patient who experiences an access site complication during an EVAR, never overlooked the possibility for leg ischemia in the immediate postoperative period. Most of these patients were hospitalized for 8 days or longer. Early identification can significantly curb morbidity and mortality. So with that, I want to thank you for your attention, and again for the program committee for the opportunity to present our work from the University of Toledo and from Bay City. I'll take any questions at this time. Thank you very much.
So I'll start with a question while we wait for anybody to come up to the microphones. Do you know if when exactly the ischemia was found? Was it found during the index operation while the patient was still on the table, or was this all after the fact while the patient was in recovery or on the floor?
Unfortunately, I do not believe that was captured by the VQI as to when exactly the leg ischemia happened. Some of the variables say intraoperative, some of them say postoperative, but the leg ischemia variable specifically does not say so. All we are able to confidently entertain is that it was reported during the immediate postoperative period, meaning before they were discharged home.
And then I'm not sure, in VQI, is there information on the extent of infrainguinal imaging that's performed preoperatively, whether there's an ABI or a CTA runoff study, for example? I'm not sure if it's in there, but just out of curiosity, because in my practice, I've gone to doing runoff studies in patients with normal creatinine in the pre-op setting just to get a great look at the infrainguinal distribution, because these leg ischemia are certainly the highest morbidity type cases we see with EVAR.
Right. As for the exact specific imaging findings, I do not believe, to the best of my understanding, that they're reported in the VQI. I know that there are certain variables, such as like fluoroscopy time, that are reported. But for this specific study, our aim was to first identify factors that we thought may be associated with this, and then those that were significant in univariates, we then put them into a multivariate model, and those that were found to be significant were what we reported.
All right. Thank you.
Thank you.
Our next paper is entitled Pedal Bypass and CLTI, A Tale of Excellent Results but Decreasing Utilization, presented by Dr. Hassan Chamsadine from Henry Ford Hospital in Detroit.
Thank you for the opportunity to present this work. We have no disclosures. The Basel II trial have shown comparative outcomes between endovascular interventions and open surgical bypass for below-knee peripheral artery disease. In cases of extensive disease not amenable to endovascular interventions, or in the setting of prior failed endovascular therapy, a pedal bypass, which involves an open surgical bypass to a patent foot vessel, expands limb revascularization options with its proven durability and satisfactory limb salvage outcomes. Nonetheless, this operation is considered technically challenging. The size of the vessels involved, their frequent calcification, the limited soft tissue coverage in the distal lower leg and foot, the presence of tissue loss in contiguous areas of the foot, and the need for autologous veins all conspire to increase the technical demands of this operation compared to a more proximal infrainguinal bypass. Those factors may affect the utilization rates of this operation and consequently its outcomes. Accordingly, the aims of this study were to first explore the trends in the use of pedal bypass, second, explore the overall outcomes of pedal bypass, and finally, study the outcomes of this operation considering different center volumes and pedal bypass targets. Patients receiving infrainguinal bypass in the VQI were queried between 2003 and 2023. Of those, only patients receiving a pedal bypass were selected, with a pedal bypass defined as a bypass to the dorsalis pedis artery, posterior tibial artery at the level of the malleolus, or the tarsal and plantar arteries. Only patients receiving an operation for PED were selected, and accordingly, those receiving an operation for trauma, acute limb ischemia, or peripheral aneurysms were excluded. The ratio of pedal bypass to all infrainguinal bypasses performed dropped from 14% in 2003 to only 4% in 2023, reflecting a fourfold decrease in the utilization of this operation over the 20-year study period. A total of 302 centers performed infrainguinal bypass in the VQI between 2003 and 2023. Of those, 56 centers did not perform any pedal bypass over a 20-year study period. The remaining 246 centers performing pedal bypass were split according to their annual pedal bypass volume into tertiles of low-volume centers, defined as those performing less than 2 pedal bypasses a year, medium volume centers, defined as those performing 2 to 4 pedal bypasses a year, and high volume centers, defined as those performing more than 4 pedal bypasses a year. The majority were low volume centers, whereas 15% were medium volume centers, and only 7%, represented by 16 centers, were high volume centers. Low volume centers performed a median of 1 operation per year. Medium volume centers performed a median of 3 pedal bypasses a year, and high volume centers performed a median of 8 pedal bypasses a year, with the highest performing center performing up to 16 pedal bypasses every year. Baseline demographics between the three center volumes varied. Mainly, high volume centers were older and more likely to be white and hypertensive, but less likely to be current smokers and to have a prior ipsilateral peripheral vascular intervention. Moreover, high volume centers were more likely to utilize an autologous vein for their bypass. Looking at outcomes, high volume centers achieved a significantly shorter operative time, but other outcomes, including hospital stay, myocardial infarction, stroke, pneumonia, acute kidney injury, surgical site infection, and graft infection, were similar between the three center volumes. When looking at the overall outcomes of this operation, pedal bypasses achieved a primary patency of 65% and a secondary patency of 80% at 1-year follow-up, as depicted on the graph to the right. Moreover, amputation and reintervention rates were considerable at 17% and 18% respectively. When comparing long-term outcomes by center volumes, high-volume centers achieved a significantly higher primary patency at 1 year at 68% compared to low-volume centers at 63%. This difference was significant on multivariate analysis, showing a 21% decrease in the risk of primary patency loss for high-volume centers compared to low-volume ones. Moreover, high-volume centers achieved a significantly lower reintervention rate of 17% compared to low-volume centers of 20%. They also achieved a significantly lower amputation rate of 15% compared to low-volume centers at 19%. Those two findings were also significant on multivariate analysis, adjusting for different confounding variables and procedural details. Looking at the bypass targets, 55% of pedal bypasses performed were performed to the dorsalis pedis artery. 33% were performed to the posterior tibial artery at the level of the malleolus, and 12% were performed to the tarsal and plantar arteries. When comparing the outcomes based on different targets, there was no significant difference between the primary and secondary patencies compared between dorsalis pedis, PT ankle, and the tarsal and plantar arteries. Moreover, no difference was also seen between the reintervention rates and the amputation rates between the three distal targets. So in summary, the utilization of pedal bypass is decreasing from 17% to 4% over the last 20 years. Pedal bypass secondary patency is up to 80% at 1-year follow-up. High-volume centers achieve better outcomes with a higher primary patency and the lower amputation and reintervention rates. But there is no difference in outcomes between outcomes of pedal bypass between bypasses to the different outflow vessels. In conclusion, this operation remains an important part of our CLTI armamentarium. The decreasing pedal bypass utilization raises the concern as to we are offering all options of revascularization to patients with CLTI. And finally, those patients may benefit from referral to high-volume centers before being offered an amputation or an alternative revascularization modality. Thank you.
We'll open
again,
to
Olamide
questions.
from Atlanta. I'm not trying to be funny, but I have 2 questions. So, do people know how to do them? That might be a question. And then you may answer it or may not. But for the second one, do we need advanced fellowships for these types of bypasses?
Thank you, Dr. Alabi, for your question. So I don't think I'm at a place to answer whether people know how to do them or not. But what I would say is the data suggests we are doing less and less of those operations, and consequently, as you do less and less, given that it does have a gradual learning curve where experience is only earned after substantial, or performance is improved after substantial experience, I believe that maybe the performance of them would be getting lower and lower with time. As to your second question, I believe this is why eventually some programs did develop limb salvage advanced fellowships, because when we have extensive cases, we need those rare operations that are not present everywhere anymore. You do need the experienced people performing them to achieve a good result.
Thank you. Very nice presentation. My opinion, the decrease from endovascular increase, the pedal approaches, etc., is taken over actually. My question to you, any data on the type of conduit, the venous, most probably it's only greater saphenous vein that you're using, or venous in general?
So
type of conduit, does it affect the patency?
So considering your first comment, whether PVI may be what's driving pedal bypass downwards, we also ran another analysis where we compared, even when we fixed the trends of PVI performed, even compared to all the infrainguinal bypasses, pedal bypasses were dropping throughout the years. We performed another sub-analysis comparing the grafts available. The grafts that were performed were used either autologous or cryopreserved grafts. Autologous veins were much superior with a very big difference in patencies. Those results will be published in our paper in GVS, accepted to be published tomorrow. So you can...
on that, is there a difference between utilization, low volumes, higher volumes for the autogenous? That will make a difference.
Yes. So we did control for, in the paper, we did control for the conduit used, and the difference was still there. High volume centers achieved better outcomes.
We're actually going to have to move on to the other paper. I'm very sorry.
Just one more thing, a shout out to Hassan. He's been my research fellow and is going to apply for a vascular surgery residency. So please, if you see his application, please take a look at it. Thank you.
All right, the next paper is People of Hmong Ethnicity Have Increased Predisposition to Aortic Dissection, presented by Michelle King from University of Minnesota.
Hi, thank you for the introduction. My name is Michelle Kong, and I'm currently a fourth-year medical student at the University of Minnesota. Today, my presentation will be on how people of Hmong ethnicity may have an increased predisposition to aortic dissection. We have no financial disclosures. So Hmong are an ethnic population from East and Southeast Asia, notably Laos, Vietnam, and Thailand. However, there was a large-scale resettlement to the U.S. in the 1970s after the Vietnam War. Currently, the largest population of Hmong live in Minneapolis, Fresno, and Sacramento. They've also been noted to have high rates of uncontrolled hypertension and other medical risk factors in the literature. Anecdotally, cardiovascular providers in the Twin Cities have noted a high proportion of Hmong patients presenting with aortic dissection. However, there has been no published data to support this impression. This led us to our first objective, which was to evaluate whether patients of Hmong ethnicity have an increased risk of aortic dissection compared to those of non-Hmong ethnicity. We also wanted to see if there were any differences in demographics, risk factors, pathology, and outcomes in this population. To explore this, we performed a retrospective review of coding data using the University of Minnesota Fairview electronic medical records over a 13-year time span. Patients with an index presentation of aortic dissection and without aneurysmal disease were identified using diagnosis codes. We then subcategorized patients by Hmong ethnicity and presence of aortic dissection. Patients of Hmong ethnicity were identified using last names belonging to one of 18 well-defined Hmong clan names. This method has been previously described to study this population, given that it's often not a specified ethnicity in the EMR. Our study included a total of 721,618 patients, of which 482 were identified as having an aortic dissection without aneurysmal disease on index presentation. Of the 482 patients with aortic dissection, 29 patients, or 6%, were Hmong, while only 1.6% made up the total cohort, suggesting that they are disproportionately affected by aortic dissection. Among patients with aortic dissection, there was no significant difference in sex. However, Hmong patients were found to be significantly younger, less likely to smoke, and with low prevalence of valvular heart disease compared to non-Hmong patients. Interestingly, there was no significant difference in previously diagnosed hypertension between Hmong versus non-Hmong patients. However, on univariate analysis, Hmong patients were found to be significantly more hypertensive when looking at their mean blood pressures and systolic blood pressures on admission. This suggests that Hmong patients may have had undiagnosed hypertension prior to their index presentation of aortic dissection. There was no significant difference in 30-day or 1-year mortality. Looking specifically at risk factors for aortic dissection, our multivariate analysis demonstrated that Hmong ethnicity conferred an approximately 6 times greater odds of having an aortic dissection. Although female sex, older age, smoking, cancer, and valvular disease were also found to be significant, Hmong patients were found to have a lower prevalence of most of these risk factors, suggesting that Hmong patients, whether it be due to genetic or environmental factors, including social determinants of health, are at a higher risk of having an aortic dissection. As with all retrospective studies, we can only infer correlations and not causality. Therefore, the study serves as a starting point for future research to investigate the relationship between Hmong patients and their associated increased risk for aortic dissection. Another limitation of our study is that it's based on coding data, which lacks the granularity for in-depth analysis. It's also important to recognize that our study is based on a single healthcare system, which means this could have led to possible under or over-representation of Hmong patients. Exclusion of existing aneurysmal disease may also limit the generalizability of these findings. We've begun future studies to address these limitations with patient-level data. So in conclusion, our data suggests that Hmong patients are at an increased risk of presenting with aortic dissection. While generalizations to the overall Hmong population require further validation, the lower age, rates of valvular disease, smoking, and less prevalent comorbidity suggest a possible genetic predisposition to aortic dissection in this underserved ethnic population. However, it's also important to recognize the role of social determinants of health, such as primary care access, health literacy, and different cultural beliefs surrounding medicine and healing that may be contributors to Hmong patients' health and their increased risk for aortic dissection. I'd like to thank you for the opportunity to present our work. I would like to thank the faculty at the University of Minnesota, divisions of vascular CT surgery who contributed to this project, and I'd like to thank Dr. Cirillo Pan and Dr. Rumi Pfizer for their support. I'm happy to answer any questions.
That was a great talk, and I like the way you're trying to figure out the genetic component of the population versus whether or not it's the health disparity. Mm-hmm. How do you plan on doing that? it's an underserved
Yeah.
minority with poor access to health care, and your conclusion is saying there might be a genetic component.
Mm-hmm.
And it's very hard to suss that out.
Mm-hmm.
How are you going to do that?
That's a really good question. I think one of the things that we have observed anecdotally, and I would also be interested in learning more about, is with regards to their family history. So anecdotally, we've had patients who are young, but also have noted to have other young family members who come in with an aortic dissection. So I think that could be one way in kind of just starting the trajectory and perhaps deciphering and teasing out between the genetic and social determinants of health. But yeah, that would kind of be my one starting point.
That's good. And I also think, you said one of your limitations is that it's a single center healthcare.
Mm-hmm.
I think that's one of your greatest advantages because you have almost a control there, and that'll help maybe tease it out a little bit. But really nice talk. I really enjoyed it.
Okay, thank you.
Yeah, the lack of valvular disease in the Hmong population, and then valvular disease having a hazard ratio of 5.4 really pushes you, I think, towards some genetic predisposition there that hopefully can be identified and in the future treated with gene therapy.
All right.
Thank you.
Move on. Thank you.
Thank you.
Okay, our final presentation of this session before break is the feasibility, development, and implementation of the first televascular care program in the Veterans Health Administration.
Good morning, and thank you for the opportunity to be here today. Whoop, I went over it. Anyhow, first slide was we have no financial disclosures or conflict of interest. The Choice Act of 2014 and the VA Mission Act of 2018 are laws that give veterans more access to medical care. Veterans who have long wait times or significant distance to travel can receive community care in the private sector by non-VA providers, and the cost is covered by the Veterans Health Administration. Because of this, the Veterans Health Administration began to see a high number of cases outsourced to the community. The cost of the Veterans Health Administration for veterans receiving community care has increased each year from $7.9 billion to $18.5 billion in 2021, and it is anticipated to continually increase to occupy more than 25% of the 2024 budget. The Veterans Health Administration wants to continue to offer high-quality medical care to veterans while reducing the cost of outsourcing. We know that rural veterans living in rural communities face unique challenges that limit their access to health care and have higher rates of cardiovascular diseases. This makes them a higher risk population, and this is the group that this program is targeting. Although common perception is that community care is better, there's good data to show that the health care in the VHA is equal to or better than non-VA care. The VA is doing a good job in caring for veterans, and our veterans appreciate it. I think it's important to note that keeping medical records in one centralized system is also safer for patients. In 2018, the same year that the Mission Act was implemented, the Veterans Health Administration introduced the National Clinical Resource Hub initiative to provide clinical and administrative coverage to areas that had shortages in primary care and mental health care. There's clinical resource hubs for each VISN in a national VHA network to support all VA hospitals. Now the Clinical Resource Hub offers a variety of specialty services. In August of 2022, it introduced a new program titled the VISN 10 Clinical Resource Hub Televascular Care Program, with the goal of providing quality, evidence-based vascular care to veterans and to reduce the outsourcing costs to the VHA. This is the first established televascular program in the National Clinical Resource Hub network. To develop this program, a VISN 10 vascular work group comprised of vascular surgeons from Cleveland, Ann Arbor, and Detroit was formed. The group determined that the primary inclusion criteria would include stable vascular diagnoses. Our top three vascular diagnoses covered in the program are abdominal aortic aneurysms, carotid artery stenosis, and peripheral arterial disease with claudication. We offer some additional services and are continually working toward expanding the criteria to meet the needs of our veterans. There are multiple steps taken to establish this kind of program. Over the course of 6 months, evidence-based clinical pathways, decision flow maps, computer templates, speaking scripts for nurses and schedulers, and patient education materials had to be established. After that, relationships with various VA centers in the VISN-10 network had to be formed and determine how a televascular program could assist them. Formal agreements then had to be arranged, as well as sharing of local protocols for emergency situations. There are 3 methods in which the VISN-10 Clinical Resource Hub televascular program can provide services. Our primary modality is a VA Video Connect appointment from home in which the veteran enters a secure video conference room from an email. Veterans who are not comfortable with technology can elect to go to their local community-based outpatient clinic and be seen via secure clinical video telehealth. This is also a secure virtual conference room, but they have the assistance of a telehealth technician. E-consult's a modality that's usually appropriate for questions regarding frequency and type of surveillance for various vascular conditions. And as a provider, I see the patient, write clear, detailed notes with precise instructions for recommendations, management, and surveillance, as well as when to reconsult vascular surgery. The program was implemented on February 27, 2023 in Cleveland, Ohio, with the Lewis Stokes Cleveland VA Medical Center, as they supported the provider in the development and implementation. The program then slowly transitioned to other sites with less robust surgery programs. We are currently assisting the VAs in Chillicothe, Ohio, Dayton, Ohio, and Detroit, Michigan. This was a single-center retrospective analysis of the data from the VISN-10 Clinical Resource Hub televascular program from February 2023 through June of 2024 to determine the number of qualified veterans that would choose a telehealth visit and be offered, when offered, and the cost reduction to the VHA. This slide shows the current estimated cost for a standard episode of care when a veteran is seen in the community. It also shows the care costs associated with patient encounters in the VHA both locally and nationally. As you can see, there's a significant cost to send a veteran into the community for care. The VHA cost savings was calculated by taking the standardized episode of care for the community and multiplying by the number of telehealth consults. Then the national average cost per encounter for vascular surgery visit in VISN-10 was multiplied by the number of telehealth consults, and that total was subtracted from the outsourcing cost to determine the total cost savings for the analyzed interval. This slide shows the data that was included in the analysis from each site in VISN-10 that we are deployed to at the time. It is important to note that we're not deployed to all sites for the same duration. So Cleveland and Chillicothe have heavier data than Dayton and Detroit. Also, the method in which consults are provided to the program varies between locations. For example, Chillicothe does not have a vascular program, so all their consults are outsourced to the community. And my team goes through all those consults and see which ones meet the program criteria. They then call the veteran and offer for them to remain in the VHA healthcare system and be seen by a vascular provider via telehealth appointment. 35% of the veterans agree to this. For other sites, the vascular program directly sends the consults to the program, and often after telling the veteran about it, so they have a higher acceptance rate. We did update our data from the original submission to include 4 additional months, so there's a little bit of variation in the numbers between what's presented right now and what's in the program. So of the qualified veterans offered to remain in the VHA healthcare system and be seen by the telehealth program, a minimum of 35% agreed to remain in the VHA healthcare system. Sparing just 1/3 of patients from being outsourced to the community will have a significant impact. During the analyzed timeframe, this program has seen 132 unique veterans via video telehealth appointments. Conversion of a community care vascular consult to a VISN-10 Clinical Resource Hub televascular program represents a cost savings of approximately $144,854. We did not include e-consults into the savings, but it's important to note that if they were added into it, the community would have been converted to a face-to-face appointment, and that would have added a significant cost to the VHA. So while veterans are provided access to private health care, many veterans prefer to remain in the Veterans Health Administration. Quality vascular care can be delivered safely and efficiently via telehealth modalities for stable vascular conditions. The VISN-10 Clinical Resource Hub televascular care program has reduced outsourcing and allowed for significant cost savings to the Veterans Health Administration. Thank you. At this time, I'll take any questions.
Thank you very much, Iraklis Pepinos from Nebraska. This is very important work. Do you have any insight into
what makes some veterans decide to stay within the system versus not. And your work is not applicable just for the VA, but I'm sure with the increase of the risk for vascular disease and the aging of the population, a lot of systems will be interested in what you do. Very nice work.
Thank you. That's an excellent question. We are finding that the veterans who are choosing to stay in the VHA healthcare system are ones with newly diagnosed vascular diagnoses. The ones that are choosing to go outsourced into the community are because they've already been followed in the community by a vascular provider and they're comfortable with them and they want to continue seeing that person. We also found that a lot of our veterans, the rural veterans, the ones who have long trips to a VA medical center, and or have chronic medical conditions with pain or mobility issues, prefer to have the telehealth appointments in their homes.
Just a quick comment and a question. I think those of us who are in the VA recognize the extraordinary amount of work this must have taken. And I just want to applaud you for this because I think we know how hard it is to get things done. My question is just how did you get this started? How did you get buy-in from the VA and the resources that were needed?
I'm going to actually let Dr. Pinot answer that one, since he is my colleague on this paper and the one who initiated the program.
I'm Gilles Pinot, Cleveland VA. I think I agree with you. I think that the key always at the VA is you push forward with strong and continued, plan to move forward. But I think the key from our perspective is I think the VA is under attack in some ways. We're under siege from politically to try to quote unquote put veterans in a position where they're going to get better care. So I think that there was a recognition in our vision that we're losing patients to the community, and the moment that the patients go to the community, we kind of lose them forever. While we think that may be a better option, I can tell you that the majority of our veterans want to stay within the system, and if we provide them the ability to stay within the system, then they will stay, and ultimately there'll be a significant cost differential, and it'll be much cheaper to take care of those patients, and it'll be cheaper for the taxpayer. So I think that I commend Liza. I think and Dr. Jean-Claude and our leadership in the vision to be able to move forward with this program.
Thank you. Thank you.
That concludes our session for this morning. We now will have a short coffee break, and I'd like to remind everyone that we will start at 10 a.m. On time for the second scientific session. Thank you.